Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in another very interesting case. So this patient was recommended to see me by a colleague of mine who's an ENT surgeon. I'll give you the backstory. So this patient, back in 2019, was struggling with their hearing, so they went to a hearing centre and they were advised that they have wax, so to have the wax removed prior to undergoing a hearing test to see whether they need hearing aids. So the patient went to their doctor's surgery and had their ears irrigated, and a couple of weeks later they developed or probably less than that, developed a really severe ear infection in both ears. I'll come back to that in a moment. So here we're using my new Rye double-ended ear correct, and you can see that I was using it to separate and elevate this dry crusted skin off the canal wall. The end of the correct is tapered and it's also narrowed, and it allows us, almost like a wallpaper stripper, to kind of elevate skin off the canal wall. Of course, when you're approaching the bony part of the ear canal, you need to be really, really cautious when using that because it can be a bit sensitive. But although the correct has a tapered and narrowed tip, it's still extremely strong. In fact, I would say it's as strong, if not stronger, than the previous Jobson horn that I used, which is a lot thicker. And that's because we're using carbon fibre reinforced instruments. So these are all single use. In the UK, there generally is a trend of using single use disposable instruments, and that's purely just to assist in infection control. You can autoclavable instruments. They're normally in stainless steel, but they can be quite sturdy instruments, and they're more likely to cause trauma to the ear canal. So it's just a trend in the UK to use single-use disposable, which various plastics. So the ones that we're using are carbon fibre reinforced, so they gives you that extra strength and flexibility. So this patient developed ear infections in both sides. Saw their doctor, was provided with the necessary antibiotics. The infection resolved, but the patient felt still that they couldn't hear as well. Therefore, I think then COVID happened, and they saw my colleague, Mr Rajali, he's an ENT surgeon, back in May, I believe, of this year, and he was advised that he's got perforations in both ears, and you'll see them. So it's a very interesting visual. Stay tuned for the right ear, guys, because if you think that's probably a bit more interesting than this ear, although this ear is interesting itself. I'm just using the ear pick there to elevate some of this skin that was crusted against the floor of the ear canal. We're on the bony part, so we're really, really gentle here. And you can see when I lifted that skin, it's moist. These are all these, as the skin decays, it releases lysosomal proteolytic enzymes, which can start decaying the skin and the underlying bone. So we still can't see the perforation yet. So my colleague, Mr. Rajali, has referred this patient to see ENT via the NHS. So the patient saw my colleague privately to discuss possible surgery and maybe an implantable hearing aid, so a bone-anchored hearing aid or middle ear implant, particularly on the right side, because on the right side they're suffering from chronic suppurative otitis media. And I'll explain that in more detail, which means they can't wear their hearing aids, so they do have hearing aids as well. Now, what I don't fully know is whether the perforations occurred secondary to the patient undergoing ear irrigation, or they were there beforehand and it went unnoticed. Both are plausible. If the patient did have pre-existing perforations and underwent ear irrigation, that shouldn't have been done, but if there's no record history of that, then the person performing it wouldn't have obviously known. The patient themselves weren't sure. Now, you're going to see the perforation there. So this patient's eardrum is retracted. It's sucked inwards in the posterior and inferior quadrant, and posteriorly is where, I would say in the posterior inferior quadrant is where they've got the perforation. So in terms, if you're looking at a compass, this is going to be southeast. The rim is slightly moist, but that could just be because of all that skin keratin that's up against it. You're going to get a view inside the middle ear, and you can just about see what we call the round window niche. The round window niche, what is that? So it's almost like a pressure valve. When the sound hits the eardrum, the vibrations are transmitted through the three bones, the three ossicles, the hammer, anvil, stirrup, also known as the malleus, incus, stapes. And the stirrup or stapes bone is connected to the cochlea, the organ of hearing, via a part called the oval window, which is almost like a thin membrane. And the stapes bone goes forwards and backwards, and it's attached to the oval window. And when the oval window moves forwards and backwards itself in response, it causes fluid within the cochlea, inner ear fluid, to travel in waves. They then travel over the microscopic outer hair cells, which then induce an electrical signal, which is sent to the brain, and we perceive that as sound. So as that fluid pressure is being is moving forwards and backwards within the cochlea, there needs to be a pressure valve. So you've got the round window, which can stretch. So if fluid is being compressed and the pressure is excessive, it doesn't leak out. We don't want that pressure to leak out or burst through out of the cochleas. If it does, you will lose all your hearing. We need the inner ear fluid. It's a constant. There's two fluids, endolymph and perilymph, and they kind of, the anic composition is opposite, and it's that what helps create an electrical charge and action potential. But we want this fluid to remain within the cochlea. If it leaks and the cochlea is completely void of this fluid, you will lose your hearing. So the round window is a pressure valve. So as that fluid is travelling waves within the cochlea, this round window can absorb that pressure, and it can stretch. So hopefully you'll see that in a moment. Also, you can see what we call the pulmonary. So the cochlea, the organ of hearing, and the organ of balance, the semicircular canals, they're connected. And in the mid-structure, you see the pulmonary, and you can see that there with the blood vessels. So if you're going through the eardrum, it is probably a bit of mucodal discharge there. And just to the right of that is like a little a black circle, almost like a black hole, and that's very likely to be the round window niche. So this is their right ear. So this ear is discharging. The patient said it's weeping, or for a while it's chronic, and you can't see the perforation at the moment because of all this mucodal discharge. So this is all originating from the patient's middle ear. So they're suffering from a condition called chronic suppurative otitis media, which basically means a middle ear infection in the presence of an unintact eardrum tympanic membrane. So there's a hole there, and all this discharge from the middle ear, it's then leaking out of the eardrum. So the perforation is anteriorly. You can see all that fluid, and I'm going to suction it away, and it's going to, the patient slightly startled because suddenly they could hear a lot better, and the eardrum itself is inflamed. So they've got some laryngitis here, and there's the hole. I got the patient on two separate occasions to mildly perform the Valsalva. So when you close your mouth, pinch your nose and blow, and you want to trap that air inside your nose. You don't want it to escape. And when you do that, that air pressure travels upwards, and that certain positive pressure, when there's excessive pressure of air in your nose, it stimulates the muscles of the eustachian tube, which is the pressure equalizing tube. So it causes the eustachian tube muscles to contract, which then in turn causes the eustachian tube, which is a narrow orifice connecting the middle ear to the back of the nose. So it contracts the muscles where the eustachian tube connects to the back of the nose, the nasopharynx, causing the eustachian tube to open. And then that air pressure travels up the eustachian tube. And the reason why I got that patient to do this, because it's very likely there was more discharge still within the middle ear cavity. So by doing that, you'll see it. The patient was able to force some of this fluid, this infected mucodal discharge. We call it middle ear effusion, from their middle ear into the ear canal for me to suction. So what I'm doing here, I'm just spending a bit of time trying to suction all this macerated skin. You can see it's very damp and broken down. Obviously, you've had all this discharge sitting on it, so it's not a pretty sight. We're not going to get every little aspect out, guys. I'm just trying to remove as much as possible. So I should have mentioned right at the beginning, this patient was extremely nervous, and understandably so, because they had a terrible experience which following ear irrigation. And again, I can't confirm whether the ear irrigation caused the perforations or the perforations are there previously. It's difficult to ascertain that. But ever since the irrigation, this patient is just suffering from chronic ear infections. So what I want to do is just remove as much as I can, as comfortably as possible for the patient. And it is difficult because we're working on the canal wall, and I want to minimize contact, because any slight contact, because of the patient's anxiety, they will move. And it's like what we're trying to do here is, you've got a bit of sticky tape, sellotape on some paper, or some sort of sticker or label on a plastic bottle, for example, and you want to peel that away, but without injuring the patient. So the action plan is, patient's already been referred to ENT by my colleague. Now, the reason why my colleague referred the patient to me is because my colleague advised the patient, of course, ENT charge a lot more than I do, and they've got a lot more overheads. Although I wouldn't say I'm cheap myself, but my colleague advised the patient, obviously, to not have irrigation performed. They're more than welcome to see my colleague, but his availability can be limited, and of course they're a lot more expensive, and so if they wish, they can come see me. So the patient just had to travel a fair bit, but he's more than happy to do that. So I've just written to the GP just to explain what we've done today. They will need some non-ototoxic medication. And what I mean by that, many of the medications prescribed for ear infections are what we call ototoxic. So if they enter the middle ear and get absorbed by the cochlea, the absorption can happen via the oval window or the round windows. It's slightly permeable. And if they absorb any of these medications, they can sometimes damage the hair cells or the auditory nerve, the inner hair cells and the outer hair cells. So what this patient requires is non-ototoxic medication. So there's those group of antibiotics that I was making reference to, those medications, they're called aminoglycosides. And they typically end in mycin. So mycin can be spelled M-I-C-I-N or M-Y-C-I-N. And what the aminoglycosides do, they just stop the bacteria from reproducing. They essentially, within the bacterial cell, you have all these organelles, one of them being a ribosome, and the ribosome is involved in protein synthesis. And there's two sections. One section reads the genetic code, the other section goes out, finds the different amino acids and brings it back to the other portion of the ribosome, which then kind of connects it all together. So obviously amino acids collectively help to bind protein. So this just stops the bacteria in its tracks. It inhibits one of the subsections of the ribosome, so it just can't basically reproduce. So what's typically prescribed for these patients when they've got a perforation is, and I'm probably terrible at pronunciation, ciprofloxacin. They are different derivatives, if believed. You can get normally for the ear. Typically, previously they were prescribed off-label. They were used for eye infections, and then ENT would prescribe off-label in cases like this for ear infections. But now they're specific versions for the ear. So again, I'm just trying to peel some of this. If I can't, fine, it's not the end of the world. Now you may see anteriorly the fluid is collecting again. Now we don't know where this fluid is coming from. Is it coming from the attic antral region? Is there underlying costoma? Typically you'll get a perforation more in the posterior superior quadrant, but we don't know. It may be leaking from there. So we just don't want the mastoid bone to be infected, which it wasn't today. And of course, if there is a cholesteatoma there, the last thing we want is that growing upwards towards the brain, to the skull base, which can then lead to meningitis, brain abscess. It can be very serious, it can be fatal. So this patient is just waiting for their appointment. Hopefully it won't be too long. Guys, if you just stay tuned for the next, I'd say, week or two, I've got some really interesting cases. They're coming in thick and fast at the moment. I've had a case of a potential canal cholesteatoma yesterday. Also yesterday, I had a case of what I suspected to be a canal cholesteatoma, possibly in the past, but maybe also a benign osteonecrosis. And I feel after seeing them yesterday, it is a benign osteonecrosis. I've had plenty of ear infections. There's some really interesting cases, guys. My mind's gone a bit blank, but I mean, that was quite a lot already. So do stay tuned. I had a grade 3 keratosis obturans. That's what I was trying to remember. That was a really interesting case. That's quite a long one. All these videos are quite long, and it's difficult finding time at the moment to upload. I'm really, really busy with all my new instrumentation, which you may have seen in yesterday's video. And I've used a couple today of the ear correct, the curved ear correct, and the tapered narrowed one. I've used the ear pick today as well. I'm not using the ear hook as much now, because I kind of prefer the ear pick. But I have used the ear hook in 1 or 2 cases, so it has got its uses. So we're just busy with the launch of that, busy with the wax scope, all the regulatory stuff, which is going really, really well. There's a lot of paperwork and documents that we have to prepare, which is all done now. I'm working on, I've touched on it previously, and I'm still reluctant to say much more until I've got my prototype, but I'm developing a new type of suction probe. And I've applied for a patent for design there. I won't say anything more until I've got my prototype, which I'm very, very close to getting now. I've been working tirelessly with the design of this new suction probe. It's got really novel features. I just hope it works in practice. In theory, it works. I have simulated it as well, and all shall be revealed in due course. So I think I've just got the patient to perform the Valsalva at this stage. You can see all that mucosal discharge, and there's obviously inflammation there. You can see this is pulsing, this discharge. So there's an acute infection there, dilation of the blood vessels, capillaries. So it's a very anterior perforation, just right of the handle of malleus. You can see it's very inflamed, wet. I'm just going to mop up a bit more of the skin now. Could leave it, but this skin is damp. It's been soaked in this infected debris. And I just want to remove it. I don't want this damp, infected skin to cause necrosis and ulceration of the skin and then lead to osteitis, which is an infection of the sheath that sits on the bone of the ear canal, the temporal bone that supplies all its blood and nutrients. There's a bit here. The skin here is very macerated. So you probably saw at the beginning of this case, the patient's ear canal was completely occluded with discharge. So it's not even fully draining out the ear. It's collecting, and you're getting a bit of weeping externally. You may have seen that right at the beginning. I did vacuum some discharge out of the ear canal. Patient was very happy. Their nerves, understandably so, were alleviated. Well, I hope you enjoyed that video, guys. Take care, keep well, speak soon. Bye.